Hello, everybody. We'll just give people a few moments to get in from the waiting room. Thank you for coming to our Iptop webinar. And once we've got everybody in, we'll just make a start. Really great to see everybody here on time and keen to hear about this topic tonight. Okay, I think we've got everybody that was in the waiting room, so we'll make a start. Good evening or good morning or happy middle of the day, wherever you are joining us from around the world. We're very pleased to have you here to hear about this topic of understanding paratonia and dementia and the impact and interventions. We've got an excellent presentation tonight from Professor Hans Hobbelen, who's going to take us through this topic. But before I hand over to Hans, I'm going to just do a couple of housekeeping things. So first, to just acknowledge that this webinar is being brought to you by Iptop, which is the International Association for Physical Therapists Working with Older People. And on behalf of Hans and myself and the board, we really hope that you get a lot out of tonight's or today's webinar. During this session, you'll see some buttons for those of you watching live. There's a button that has Q&A for question and answer. So please use that to type in questions that you might want me to ask Hans at the end of his talk. Please try and avoid using the chat button because we're not monitoring that one tonight. It'll be all through the Q&A button. This webinar is being recorded and the recording will go up on Iptop's YouTube channel in about 7 to 10 days. And so there'll be a link to that on the Iptop website, but give us a week or so to get that up. As I said, tonight we've got Hans Hobbelen speaking to us about this topic of paratonia. He's going to talk for about 20 minutes and then there'll be around 10 minutes of time for question and answer where I'll pose your questions to him as you won't be able to ask the questions yourself. There's also going to be an evaluation survey at the end. I'll put it in the chat. If you miss it in the chat, it'll also come up for you when you exit the Zoom meeting, and it'll come again in an email tomorrow because we really want your feedback. So please give us your feedback. But with that, I'm going to hand over to Hans, who will present his presentation.
Okay, Mel, thank you very much. I share my screen. So, are you able to see my screen?
Yes. All good.
That's great. Okay. Well, welcome at this webinar on paratonia. It's great to have you all here. My name is Hans Hobbelen. I'm a professor in aging and allied healthcare and head of the research group Healthy Aging, Allied Healthcare and Nursing at the Anse University of Applied Sciences in Groningen, the Netherlands. And I'm currently president of Iptop. Well, 35 years ago, when I started as a physiotherapist in a nursing home, I encountered this problem. These kind of patients, late-stage dementia patients, with a lot of problems in caring. Washing and dressing was almost impossible, and the quality of life was really miserable, really low. And they asked me as physiotherapist to do something, and well, at that time, we did passive movements, so try to relax the muscles because there was a large a high muscle tone, and try to improve the range of motion. But well, I didn't understand what I was doing. I didn't know what the problem was. So I started to dig into the literature. Well, the problem was called paratonia and already described in 1828 by Friedlander, an Austrian, and later by Dupré in France in 1910 as the inability to relax muscles in the setting of cognitive impairment. In 1927, a German physician, Kleist, observed oppositional paratonia, a hypertonic response to passive movement, and gave the German word Gegenhalte, which is all still active in the present scientific literature. It just means to move against. In 1949, Kroll described vacillatory peritonia, which is pathologic assistance, actively assisting passive movement or involuntary cooperation. In this scientific literature, it wasn't very clear what peritonia was really about. So in 2006, I performed a Delphi procedure to have a consensus definition on peritonia. And this is the result of this consensus in a Delphi procedure. Peritonia is a form of hypertonia in patients with dementia with an involuntary variable resistance during passive movement. The nature of peritonia may change with progression of the dementing illness from active assistance, also in German called Mitgehen, to its active resistance, Gegenhalt, or oppositional peritonia. The degree of resistance varies depending on the speed of movement. It's a very important element of peritonia. So with a slow movement, you have low resistance. With a fast movement, you have high resistance. The degree of peritonia is proportional to the amount of force applied. Peritonia increases with progression of dementia. The resistance to passive movement is in any direction, so there's no clear pattern as you, for example, in stroke patients, a flexion pattern or an extension pattern. So that's not the case in peritonia, and there's no glass knife phenomenon. So 2006 was the start of my PhD study on peritonia, and in 2020 we performed a systematic review to look what the current state of art was on the research on peritonia. And what we found was that this new consensus definition was used most often in those 15 years, and the prevalence of peritonia was estimated 5 to 10% in the early stages, up to 100% in the late severe stages. And this is oppositional peritonia. The vacillatory peritonia part is not well researched on, so it's not well investigated. So in the early stages, most of the patients have already vacillatory peritonia, so they are moving along, they are not able to relax, but that is not well investigated. So these prevalence figures are from oppositional peritonia. Looking into the pathogenesis of peritonia, well, there's not much to go on. Of course, there's a central nervous system-based etiology. There is a brain disease, and that causes the movement disorder. But it's very likely that peripheral biomechanical changes interfere with or accelerate the severity of peritonia. So to investigate this part, I performed a longitudinal study to investigate factors influencing the development of peritonia. And I investigated 204 participants with early stage dementia, of which 133 had no peritonia. And that was the group I was interested in. I followed them a year, and 51 developed peritonia and 82 did not. And here, my moment of glory as researcher came, my eureka moment with this logistic regression. There are two factors that were statistically significant. One, we already knew, the MMSE, cognitive state of a person. With decline of cognition, we see improved risk, an increased risk of getting peritonia. But this one, we didn't know at all. There was really a novel finding. That is, patients with diabetes mellitus had 10.7 times higher risk to develop peritonia. And well, we were really, excuse me, we were really surprised by this finding, and we didn't know what to think of. So, digging into literature, we formed a hypothesis, and we thought that maybe due to the forming of advanced glycation end products that causes cross-links in collagen that can enhance stiffness of the tissue. And to investigate this hypothesis, we did the Parage study. And this Parage study was done by Hans Drent, a PhD student of mine, looking into what effect advanced glycation end products has on movement, on motor function. And he discovered that high advanced glycation end levels are a factor in motor function decline in healthy aged, not dementia patients, but also healthy aged people. Higher age levels causes muscle function decline in functional mobility, it increased physical frailty, it decreases physical activity, and it shows ADL disability. And also, it is also a factor in patients with dementia in the development of Paratonia. So our current insight is that high levels of advanced glycation end products, abbreviated as AGEs, affect motor skills and can induce Paratonia. The forming of advanced glycation end products is a normal aging process, but it's accelerated by diabetes mellitus and also by Alzheimer's disease. And with this age accumulation, we see motor function decline, with walking impairment, decrease of muscle strength and mass loss, and Paratonia. We see a decrease of functional performance and ADL impairment, which results in physical activity decline. And this in itself will accelerate age formation and age accumulation. So this is a vicious circle. And this vicious circle is the only way to break this circle is with physical activity. And I will tell you a bit more later on in this webinar. Back to Paratonia in itself. How can we assess Paratonia? We have developed an assessment instrument, Paratonia assessment instrument, a standardized method to clinically identify Paratonia and differentiate it from other forms of increased muscle tone, such as Parkinsonian rigidity and spasticity. And that's very important to do, because most often I've seen that many times in my clinical practice, that it has been misdiagnosed and that the hypertonic state was diagnosed as Parkinsonian rigidity, and that patients were given levodopa as to try to reduce the muscle hypertonic state. But of course, as it was not Parkinsonian rigidity, it didn't work. And then again, physicians were very reluctant to stop this medication because that has also also side effects. So it's very important to have the right diagnosis. It's too long to give the right instructions in this webinar for performing the Paratonia assessment instrument, but I can tell you in a few weeks, the beginning of September, there will be an instruction film available on the website paratonia.org, which we will give instructions on how to perform the Paratonia assessment instrument. It is in Dutch, but with English subtitles. Once we have diagnosed Paratonia, we can assess the severity. And that's most often done with the modified Ashworth scale for Paratonia, with 0, no resistance to passive movement, 0 plus active assistant, vacillatory Paratonia, 1 slight resistance, 2 more marked resistance, 3 considerable resistance, and 4 severe resistance. But the modified Ashworth scale is the worldwide standard, but it's prone to subjectivity, and clinical experience is necessary. So it is reliable, yet dependent on your experience. So we try to find a new way to assess the severity of Paratonia, and we thought maybe this device, the Myoton Pro, was a way of doing this to more objectively assess the severity. It can assess tone, elasticity, stiffness, creep, mechanical stress relaxation, and was already validated in stroke and Parkinson's disease. We did the study on Paratonia, and it has potentially applicable for cross-sectional studies between groups, but less suitable to measure intra-individual changes. So if you use this device, we don't recommend to use the device in daily clinical practice, but if you use it, you should interpret it with care because of the inherent variability and movement resistance in Paratonia. Another way to assess Paratonia has been investigated by Lucio Marinelli from the January University, looking into Paratonia with EMG, with the biceps and the triceps in a passive movement passive movement frequency, try to really visualize Paratonia. And here you can see the results. This is the first time ever we have really visualized Paratonia. On the left side, you see a sinusoidal movement, frequency of flexion, extension of the arm. On the top, we see the biceps, in the middle, the triceps, and on the bottom, we see the frequency of flexion, extension. And from flexion to extension, normally passively moved, no muscle should be active. Well, what you see is that the biceps is working against the extension. So that's what we call oppositional Paratonia. Here on the right side, it's a different frequency in movement. We see the same. From flexed state to extension, we see a peak of the biceps, which is called oppositional Paratonia. But from extension to flexion, that's the movement the biceps should make. We also see that the biceps is active, although it was instructed to relax. And that's vacillatory Paratonia. Currently, we are replicating this study with young people, healthy older people, and mild cognitive impairment people and people with dementia. And we are combining EMG with EEG to look into what the brain is doing while we are moving, what is going on in the brain. And one of the hypotheses is that decreased inhibition from the frontal cortex in Alzheimer's disease causes the uncontrolled muscle activation. And the first results of this study shown, this is from young students, 20, 25 years old. What you see is very important to acknowledge that when you raise the frequency of the movement, the passive movement, you will see that the inhibition is declining. And we think that with mild cognitive impairment and dementia patients, this decline of inhibition is more prominent because of the brain damage, and that is one of the causes of the high muscle tone of the development of Paratonia. So despite our efforts to have a more objective assessment instrument, we didn't succeed yet. So currently we have the Paratonia assessment instrument, and we have the modified Ashford scale to assess the severity of Paratonia. In our review, a systematic review from 2020, we also looked at what are effective interventions in this late stage of Paratonia, late stage dementia with severe Paratonia. There's not much research done. There is a small study by Gallet Kleiner on botulinum toxin from Canada, Toronto University. She's currently raising money for a larger randomized clinical trial to look into this. It appears there is, well, reason to believe that there is some effect, but it's a very small study, so it has to be replicated and in a larger scale. There's a study from Bieke van Deun from Ghent University in Belgium, looking into so-called harmonic techniques that are rocking movements, slowly, passively moving in a gentle way, rocking the limb, and it shows some relaxation of the muscle. The only drawback is that if you have this relaxation and you try to go to the end of the range of movement, then you will see a negative effect, which I will tell you more about when we're going to passive movements. There's a study by Ivan Boutmans and colleagues on cervical mobilization to improve swallowing function, because swallowing is also affected by Paratonia. This is a very specialized intervention. So read the article, but be aware that this is a very, very specialized intervention, and you need really the skills to do this. Then in the Netherlands, and I'm not sure if it's used in other countries, but in the Netherlands we use good stabilizing cushions to try to relax the patient. And well, in my early days as researcher, I did a very small study with 5 patients in comparison with patients without these good stabilizing cushions, and we saw some positive results. But no other studies are available. Not so we do need more studies on a larger scale on this this topic. Very curious if it has been used in other countries, or it is still used in other countries. So anyway, I'm curious what other countries are doing against severe Paratonia. So if you go to the website paratonia.org, you can fill in a form, a questionnaire. I'm very interested in the knowledge you have in daily practice. So finally, I did a large research on passive movement, as the way we did it in the Netherlands, 3 times a week. Try to relax the limbs and then go to the end range of motion to try to stretch as far as we were able to prevent contractures. And this way of passive movements is not effective at all. It is even harmful for the patients. So they probably other literature is also on this topic in contracture prevention, that maybe there is some harm on the sarcomere level of the muscle, and that it becomes stiffer than it was before. So passive movements to the end range of motion is not effective at all. So with this limited evidence on interventions in the late stages of the disease. And with our findings of the role of advanced glycation end products, we think it's best to focus on prevention, and that exercise is medicine. So to have this intensive glycemic control with nutrition and physical activity, that may be the key methods for decreasing advanced glycation end formation and potentially prevent Paratonia. To improve physical fitness and control the accumulation of advanced glycation end products. When I started 30 years ago as a physiotherapist in a nursing home, many patients were in the end stage of the disease with this high muscle tone, with severe Paratonia. And what we currently see is that the last 10 years, this severe Paratonia is, in the Netherlands at least, far less. And we had a policy of more stimulating of physical activity, and maybe that is the key to prevent this last severe stages of Paratonia, and to improve the quality of life of these patients dramatically. Also, physical activity has been shown to preserve cognitive function, so that is really the only medicine available. Other medicine is not effective as far as we know. To end this webinar, I will point out that our editorial of the board of Iptop wrote this editorial in the European Rehabilitation Journal. So not only that, we as physiotherapists have a role in prevention and treating patients with Paratonia, but we are really pivotal in the care of people living with dementia to keep the physical fitness and physical activity of these patients and to improve the quality of life. We are really essential. Thank you very much for your attention.
Thank you so much, Hans. That's an excellent overview of a really important topic. So maybe if you stop sharing your screen, and yeah, we can have a conversation. So for those of you in the audience who have got questions, please put them in the question and answer box. And we've got one very quick off the mark, which is a very good question, because you've sort of mentioned Alzheimer's, but the question is, how common is Paratonia with other types of dementia?
Yeah, that's a good question. What we know that is in vascular dementia, Paratonia is also present. And that's the only drawback is that our assessment instrument is not able to really differentiate between spasticity and Paratonia in the late stages. In the early stages, that's very clear, but in the late stages makes it very difficult. So we really need to dig in that more deeply. But as far as we know, Alzheimer's disease and in vascular dementia, it's not present in Lewy body dementia or Parkinson's dementia. That is really clearly different as Parkinsonian rigidity.
Mm-hmm. Yeah, okay. So another question is, what might be the early signs and symptoms that we could recognize to see that Paratonia might be a problem that's emerging?
Yeah, well, the movement disorders are really the first signs of dementia. We know of studies that show that 12 years prior to mild cognitive impairment, the walking speed is declining. So there's a very early sign, and one of the early signs is vacillatory Paratonia, so not able to relax when you passively move. But that's for most people very difficult. So the early sign is slowing down. The early sign is that we feel some resistance, and mostly that is when people are in the early mild stages of the disease.
Hmm.
So beyond mild cognitive impairment.
Yeah. And so if someone is watching this webinar and they're going back to a residential facility tomorrow, and they kind of recognize that they're working with residents that are sort of already lost that ability to walk and mobilize, but they want to try and do something to help with the paratonia. What are the options for physical activity after someone's lost that ability to be up on their feet?
Yeah, that's a good question. It's very difficult. So every activity, every opportunity to activate your patient is very important. So active movement is really key. And one of the things that you can always still try to figure out what movement is still there, which is still if we when we learn movement and we have very frequent movements, they will be stored in the brain as a motor engram, and we can use this motor engram. So if you have a house painter that did up and down painting, you can try to give a brush and see what happens.
Hmm.
So that's really key to have this information from the family, from relatives. What did this person do in his past? What kind of movements can we trigger that are still there?
Hmm. Yeah, yeah. There's a couple of things around differentiating paratonia from spasticity, and also a query about whether or not baclofen might be a medication that would work, which is more associated with spasticity management. Can you talk a little bit about those differences?
Yeah, about the baclofen, that has been tried mainly to look if botulinum toxin is a potential effective medication, because baclofen is a short-lived medication. So that's so they give they if it's effective, botulinum toxin will also work. So
Hmm.
that's important. And the differentiation between spasticity is very difficult because we have the speed dependency of the resistance. So if you have a low speed, you have low resistance, high speed, high resistance. So that's also the same in spasticity, but you don't have a clasp knife phenomenon. So that's one of the reasons, and there's no clear pattern. If you have spasticity due to stroke, you have a one-sided spasticity on the left or the right side. That's not the case in peritonia. It's more generalized peritonia disorder. So
Hmm.
there are some differences, and if you have a lot of experience, you really feel the difference between spasticity and peritonia. But that's with experience. So
Yeah.
that's difficult to explain. Yeah.
Yes, yes. And is it a sort of a similar clinical experience feel to differentiate between the rigidity of Parkinson's and paratonia? Is the cogwheeling something that you don't get in paratonia, but you do in Parkinson's? Are there other
Yes,
features that differentiate?
indeed. Cockwheeling is not is absent, and uh, well, with Parkinson's rigidity, you have the lead pipe phenomenon. So there's no speed dependency. No matter what you do, the resistance stays at the same level, and that's a real clear differentiation element. Yeah.
Yeah, great. So there's a question about splints and a question about cushions. So could you maybe talk about what sort of supportive cushions in particular that you use, and whether or not splinting has any role?
Yeah. There is a wide variety of cushions available in the Netherlands. I don't know what is available in other countries, and they are most often with very firm material, enabling patients to, well, that's the thought, at least, that with a lot of sensory information from this cushion, there is the ability to relax, that the brain gets the signal, it's okay, no problem, you can relax. But that's no scientific research has been done on that uh, um, premise. So that's very splinting is also a part in contracture interventions. They are not effective at all. So we know about from literature from contracture that there's no effect in splinting and improving the contracture. And I have no information that splinting is used in Paratonia patients.
Mm-hmm. Yeah, right. And so back to those sort of differentiating features of resistance in Paratonia, is there any sort of regional pattern? So Parkinsonian symptoms tend to be more one-sided. Stroke symptoms are associated with the part of the brain that's been affected by the stroke. Is there any sort of regional pattern in the body where Paratonia might appear?
That's interesting. The information we get from our from clinicians is that it appeared to be starting in the arms, that the arms are affected as in a very early stage in moving along, but also in the resistance part, and the legs are a bit later in that, but no research has been done. So it's just from the clinical observations, not structured, but just clinical observations of physiotherapists working with patients with Paratonia.
Mm-hmm. Yeah. So we're about to be out of time, but I think for the last question, which is an important one to ask, is are there any clinical guidelines available yet, or any plans for clinical guidelines to be available for clinicians?
Yeah, we're trying to write clinical guidelines, which is very important. On the website peritonia.org, we have all the information available, which is currently what we know currently. It's not all. There is an English page to read it, and we try to write a clinical guideline very soon. But it's also with very limited resources, so that's a problem always. Yeah.
Yeah, yeah. Look, we have run out of time, but I'd just like to thank you so much for sharing your knowledge and expertise, and helping to shed some light on this issue of paratonia and what we can do as physical therapists or physiotherapists, depending on where you work, to help people that might be experiencing paratonia, or trying to help prevent the problem with that exercise intervention and physical activity to prevent wherever possible. So thank you so much for sharing your knowledge and your expertise.
You're very welcome, and all attendees are. If they have a question, they can reach out to me. They're always welcome. Yeah.
Yeah, perfect. Thank you. For those that are here, please use the evaluation survey and let us know about the webinar tonight, but also what else you might want to hear in future. But with that, I'll bring it to a close. Thanks, Hans.
Thank you. Bye bye.